the chat, and Lisa and Karen will take a look. If it makes sense, we can always stop my talk in the middle and have a conversation if a pertinent question comes up, or we can also save them to the end, and we should have plenty of time at the end to talk and answer some questions. But the title of this talk is Making Advanced Care Planning Easier for Both Patients and Caregivers. And really, I want to leave you with some really just practical tips from the Prepare for Your Care program so that you could use that in your own organization or clinical setting. So the objectives are to talk about health literacy and advanced care planning. I know many of you probably already know definitions, but we'll go over that. Talk about the challenges and opportunities, and then how we've sort of dealt with those challenges in the Prepare for Your Care program. Give you some tips and things about how we actually developed this using clear health communication principles. Talk a little bit about the evidence behind it. And again, like I said, ending with some really just practical day-to-day tips and tricks for you. So I don't think I need to tell this group, but I will just put it up here just in case, about the definition of health literacy, which is the degree to which individuals have the capacity to obtain, process, and understand basic health information and services needed to make appropriate health decisions. And I think, as many of you know, there are many components of health literacy. So it's not just reading and writing, but it's listening and verbal communication, which definitely comes in when we're talking about advanced care planning conversations. There's numeracy, like computational skills in interpreting and evaluating risk. And again, when we're talking about things like prognosis, that comes into play. And then, self-efficacy, or somebody's belief that they can sort of engage in their readiness to do that. So let's talk a little bit about advanced care planning, the definition, and then our Prepare for Your Care's definition of advanced care planning. I will say advanced care planning has been around for a long time. And usually when I say advanced care planning, most people say like, oh, right, advanced directive forms. Sort of in 1991, there was a Patient Self-Determination Act that was enacted, and that really focused on being able to document people's wishes. And so that's kind of been the standard definition. And I'll just tell you that I had pulled together a Delphi panel of over 50 international experts who do advanced care planning. So they were experts on advanced care planning, and we were pulled together for a completely different purpose. We were looking at outcomes and research for advanced care planning, and we had to stop that study because these 50 different advanced care planning researchers couldn't sort of agree on a definition for advanced care planning. So that's why I'm putting that out here now, that we actually published a consensus definition in 2017. And through that sort of democratic, Delphi panel is like a democratic process, we came up with this definition, which is an evolving definition, that it's a process that supports adults at any age or stage of health in understanding and sharing their personal values, life goals, and preferences regarding future medical care. And you'll notice in this definition, it isn't a one and done or a one-time thing, and it's not just about a form. You'll also see that it's focused on sort of future medical decision-making. When I think about like our Prepare for Your Care program, which I'll tell you more about, we sort of take this a little bit of a step further, where in addition to this being a process, that we really want to prepare people for communication and decision-making about their values, quality of life, and goals regarding both current and future medical care. So that's how maybe our Prepare for Your Care program is a little bit different than your standard advanced directive only program. But I'll tell you more about that in a bit. And I would say the other thing about the goal of our program is really to think about how we can move advanced care planning upstream. This is a schematic from an advanced care planning program called Respecting Choices, for those of you who may know that program. And they sort of talk about the conversations that you might have with someone in terms of first steps, next steps, and advanced steps. And people, I think, often think of this in terms of somebody's life course, but we also think about this in terms of readiness to engage. So I think many of you in the audience may know people who have sort of terminal disease, might be in their advanced steps in their life course, but still in the first steps in terms of their readiness to actually start having a conversation. And so we're trying to help people engage and decrease that activation energy. And again, I'll tell you more about the program in a bit. So why is advanced care planning important? Well, we know from studies that it improves patient satisfaction with care, reports of quality of life, surrogate and clinician communication, and I think, really importantly, and what we hear from patients, that is one of the most important things about advanced care planning in terms of lessening burden on other people, is that it's been shown to decrease stress and grief for surrogate decision makers. Unfortunately, the realities of advanced care planning are that the rates that people are engaging sort of nationally have been on average about 33%, sometimes lower, sometimes higher in different studies, but it's been pretty stable for the past 10 years. This has been shown to be lower in racial and ethnic minority populations, about 15 to 20%. And even if people complete an advanced directive, only about 10 to 20% of older adults report that they actually discuss these wishes with a clinician and that these wishes are in the medical record. And a colleague of mine conducted a study showing that ICU decedents or people who passed away, about 20% of people had no advanced care planning on file before death. So I guess we could do a little bit better. And this cartoon kind of sort of talks about the deer in a headlights effect. So once you've been caught in the headlights, life seems somehow inexorably changed. And I think as someone who is, a daughter and a granddaughter and a niece who has been in a situation being a surrogate decision maker for other people, and anyone in the audience who has either helped patients, has either had to deal with medical decisions themselves or been a surrogate decision maker, you know that it can be sort of one of the hardest jobs, to do that. And so how do we keep people from feeling like a deer in headlights? And I think when we think about this, patients and surrogates, they need preparation. So clinicians cannot make recommendations or guide people in decision making without knowing patients' values and needs. And sadly for patients, this is highly individual. So it can only be provided by the patient or surrogate. And you can imagine without preparation, patients and surrogates are not going to be able to communicate their values effectively or even be able to identify what they are. And when you think about what happens in the clinical environment when people have to call EMS or come into the emergency room, or there's a lot of, things that are happening in a hospital stay, that having stress, and I would also say no prior relationship with many of the doctors and other clinical staff that they might be talking with. If we don't prepare people, it's really sort of not fair to ask patients and surrogates to just all of a sudden step up to the plate and be able to sort of make these decisions in the heat of the moment. So let's talk a little bit about challenges and opportunities when it comes to advanced care planning and some of the things that we had to address. So first of all, I'll say that advanced care planning is actually pretty complex. Like I said, I think that traditional definition of just being about advanced directives really doesn't hold up when you think about the multiple stakeholders that might be involved in advanced care planning. We just published this scoping review about deconstructing the complexities of advanced care planning outcomes. And this is one of the figures from that study that was in JAGS. But you can see there's many different people involved. There are the patients or people, surrogates, there's the community, and this is where social norms are sort of established. Clinicians, there's health systems, so the electronic health record, and can they actually capture this information, and policy. So there's different things like advanced directive laws and those sorts of things, which we'll talk about. And then here are some of the challenges and opportunities that I'll talk about as well. So outdated models of advanced care planning, which we've started to talk about, health literacy, which is what this talk is mostly about, language diversity, cultural diversity and health disparities, visual, hearing, and cognitive impairment, digital literacy, and then legal challenges. And so I'm just going to touch on each of these. So the outdated model or advanced care planning definition has been to have patients make treatment decisions in advance of serious illness. And this is usually CPR, mechanical ventilation. And the focus has been on a one-time advanced directive, like a DNR, do not resuscitate order, sort of checkbox on an advanced directive. And the problem, the focus on treatment decisions only is actually flawed for several reasons. One being prediction. So we know from many, many sociologic and anthropologic studies that people cannot predict what they're going to buy at the store or order for dinner at a restaurant 30 minutes ahead of time, much less the exact medical treatment that they would want in every clinical context next week, next month, or 10 years from now. We also know that people, as humans, we are very adaptable. But people will report, oh, if I were in that situation, if I were in a nursing home and I were bedbound, that would just not be a good quality of life to me. But we do know that people adapt to their environment in different contexts, and many people can adapt to those situations and will change their goals for care. And I would say that the reverse is true, that some people may think they can adapt and then get in those situations and realize that they can't. And then there's extrapolation. And what I mean by that is you might have a DNR checkbox in your chart, but how does that help the patient or the clinician or the family members decide about whether treatment makes sense, whether somebody should go to a nursing home, should we try this chemotherapy? There's just a lot of other decisions that it's hard to extrapolate if we're only focused on, CPR in terms of a treatment preference. The other thing is that we know sort of what matters most to people is not the treatment, but the outcome of treatment. And I show this picture of a cart before the horse. I think as a clinician, we have been trained to ask people, oh, do you want CPR, mechanical ventilation? And we're really starting with the treatment. So intubation or CPR, that's really the cart, when really maybe what we should be starting with is how their life will be after the treatment, what I'm calling the horse, or what their quality of life is, how do they define it, and what does that mean to them? And then will those treatments actually get people the treatment that is most important to them? We'll come back to this when we start talking about the PREPARE program. But let's talk about health literacy. So this cartoon says, you don't call this a legal document, do you? I can understand every word of it. And Lisa and Karen and I were talking in the beginning of this, before this call, about how it's almost much harder to make something easy to understand than to just use legal language and get it done. And that's really what has sort of happened with advanced directives. So many of you know that the average reading level in the US is only at the 8th grade level. And for Medicaid and the elderly, it's at the 5th grade level. Yet we know that advanced directives traditionally have been written beyond a 12th grade reading level. This is sort of a picture of an advanced directive that was being used at our county hospital for many years. It was written in 8-point font. It had no white space that you can see there, and was really difficult for patients to read and was intimidating. There is language diversity. So 61 million Americans, or about 20%, report that they speak a language other than English at home. This includes 40 million Spanish speakers and 3.4 million Chinese speakers. There's cultural diversity and real disparities. So many people will report holding what we call non-Western views on autonomy and decision-making. What I mean by this is about 20% of patients in our studies will report that they don't want to make their own medical decisions. They want their family to do it, or they want to do it in sort of a group way. And I think it's really important to understand that people have experienced real racism at the hands of clinicians and health systems. And people report that these systems are very untrustworthy. And so if people do not trust things in the clinical setting, how can we engage people in their communities or provide them advanced care planning information in a way that works for them? When we talk about, I'm a geriatrician, so some of the things we think about for older adults are sort of vision and hearing impairment and how that might affect advanced care planning. So visual impairment, we know that 35 million people over the age of 65 have some sort of common eye condition that can affect their ability to read or see, and 12 to 15% have vision loss. And hearing impairment is also very common. So about 25% of people over age 65 report some hearing impairment. And again, I can tell you as a geriatrician, many patients sort of, I think, will pretend that they can hear what I'm saying and then find out that they've missed half of, our conversations. And when you're talking about advanced care planning or end of life preferences, that's sort of important. Also cognitive impairment. So mild cognitive impairment, these are people that have some difficulties with their memory, but may still maintain decision-making capacity is about 15% for everyone over age 65. And for people over age 85, that's about 25%. But then we also know that about 6 million people have dementia in the US, and it's really sort of important to think about advanced care planning before people lose decision-making capacity. And also think about our tools and materials and making sure that people can understand them. Limited digital literacy. So we know that 73% of older adults use the internet, which is great. And I can just tell you that even over the past 5 years, this has increased exponentially. But we also know that only 60% are able to send an email, fill out a form online, and things like that. So we really need to think about those things, especially if we have like Prepare as an online program. Other things we know about digital literacy is that there are large disparities. So people who are 65 and up and people who are in low income categories have a higher percentage of people who are non-users or internet users only, but don't have other basic digital literacy skills. And when we think about the digital divide and patient portals, only 50% of patients aged 50 to 80 years old access patient portals. 84% of those people will check labs, but then after that, things really drop off. So 37% schedule an appointment, 26% use it to get advice. And again, when we're thinking about advanced care planning and advanced directives and doing some things in our portals, not all of our patients are accessing them. There are also legal challenges. So we know that each state has their own advanced directive laws, which makes this really complicated when we think about advanced care planning. So they have tried and failed since the 1990s to have one federal statute to make this easier, but states sort of want to still do their own thing. And there are a lot of execution barriers, especially when we think about older adults and people with limited health literacy. Many states do not allow oral advanced directives requiring multiple witnesses and or a notary public signature. And then some states still require mandatory legal language. So even if you wanted to make it easy to understand, you can't because you have to use this language that's dictated by the state. And I would say advanced directives are really sort of high stakes, especially when we're talking about health literacy. And these checkbox responses can have life and death consequences. There are many studies showing this, but I'm just going to read an excerpt from one of our focus groups that sort of really gets to this. It says, my mom passed away and she had signed the paper, the advanced directive, in the hospital, but it was totally wrong because she didn't really understand it. So then we had another one filled out, and that one said, do you want to be resuscitated? Do you want to be on a machine or not? And she said no. And then the questions were getting in conflict. One said yes, one said no. That really confused us. And so she got frustrated and she didn't want to talk about it anymore. And I have to say that, as a geriatrician and a palliative medicine physician in the hospital, I see this all the time, that people fill out these forms and you ask them, well, what does this mean to you? And they can't either remember that they signed it, they didn't know what it was that they checked off. And when we're talking about CPR, mechanical ventilation, this is kind of, as I said, sort of high stakes. So now I'm going to turn to talking about Prepare for Your Care and some of the clear health communication and development tips that we sort of learned along the way. So we needed to address these challenges, right? Outdated models of advanced care planning, health literacy, language diversity, cultural diversity, visual hearing impairment, digital literacy, and legal challenges. And so again, that outdated advanced care planning definition, which is sort of a one-time advanced directive really focused on treatment decisions, we spent a lot of time thinking about how, that we can evolve the advanced care planning paradigm. This cartoon says, I'm afraid you've had a paradigm shift. And I can't believe it now, but it's 11 years ago. My colleague Terry Freed and I published a paper in the Annals of Internal Medicine calling for the redefining of the planning in advanced care planning. And that was really calling from, only focusing on life-sustaining treatments, which are also important, but really to focus again on that preparation for communication and decision-making, which patients and surrogates are really need. So we talked about already what matters most, and that's really what someone's life will be after treatment, rather than just, CPR, mechanical ventilation. And so focusing on those things. And so we kind of pulled all that together into our Prepare for Your Care program. So Prepare for Your Care is an online HIPAA compliant advanced care planning program in English and Spanish, and it's free to the public. And it also includes our easy to read advanced directives. So we created actually these easy to read advanced directives first. So this is maybe over 15 years ago now. These forms are written at a 5th grade reading level. They have pictures to help explain the text and a lot of white space. And we had conducted a randomized control trial among English and Spanish speakers at our county hospital. And we showed that this easy to read form was able to double our completion rates from baseline, and that people overwhelmingly preferred this form regardless of their literacy or their language. And we find this, I think, in health literacy all the time, that even people that have high literacy still prefer to do things like their taxes or informed consent or advanced directives in something that's easy to read and understand. We have this advanced directive in 10 different languages in California, and actually for all 50 states in English and Spanish, including a growing number in Chinese. And for New York, we have it in English, Spanish, and Chinese. And the advanced directive may look different from some of the advanced directives that you're used to, because we've included many more things about people's values and quality of life and space to write the why. I would say as a provider, again, at the bedside, you could have a checkbox, but what's more important to me is, why did somebody check that off? What were the things and the stories about them, their family members, or how they're feeling that will really help me understand why they chose that and how that we can extrapolate that to clinical care. But the question really has remained for us after we created our easy to read advanced directives, and we thought, oh, we just solved the problem in advanced care planning. We've created this thing that's easy to use and read, and we just get everybody to complete this advanced directive, and then all problems will be solved. And as we continue to talk to our community and to people who've actually been through these difficult medical decisions, we learned that maybe advanced directives are not enough. And I'm just going to read you this quote from a surrogate decision maker. She said, "We got the DNR, do not resuscitate, in writing, but in making the decisions, which there were many, that was just one, because the first decision was to put him in a nursing home. We were married 30 years and I could no longer take care of him. Then the second decision was whether to put him on a feeding tube because he had stopped eating and I wasn't ready to let him go." So the advanced directive is one thing, and then there's all the other decisions and things that need to be thought through and prepared for. So we realized, again, in talking to our community, that there really were some missing puzzle pieces, and specifically the piece to prepare people with skills so that they can identify what is most important to them and how they want to live. We sometimes assume people just know this, but they really need to be walked through that process. And then really how to talk with family and friends, how to talk with medical providers, especially if there's a power differential there, or that person is seen as someone that they cannot trust, how to make informed decisions, and how to get the care that's right for them and empower them to speak up. So again, that's why we created the prepareforyourcare.org interactive multimedia website. There are 5 steps of a Prepare program, and we learned this from our community members and doing a series of focus groups. So 1, choose a medical decision maker. 2, decide what matters most in life. 3, choose flexibility for your decision maker. 4, tell others about your wishes. And 5, ask doctors and medical providers the right questions. Each of these steps take about 10 minutes. They can be done all at once, sure, but they also can be done just one at a time, or for whatever the steps that are most pertinent to people. And in creating Prepare, I think the biggest lesson that we learned was co-creating the materials with diverse populations. And I'll talk to you a little bit about that cultural adaptation model in a moment. We wanted to make sure that, just like the advanced directives, it was easy to understand. So it's written at a 5th grade reading level. There are voiceovers for individuals who might have difficulty reading, and closed captioning in English and Spanish for people who have difficulty hearing. And we really tried to have a range of video stories on things like surrogate availability. We've learned from our studies that about 15% of people will report that they don't have anyone in their life that they trust to be a surrogate decision maker. And so we needed to have tailored information about that. As I told you before, people have differing views on decision making. So if about 15% of people report that they don't want to make their own medical decisions, we really needed to have tailored content so we could still engage those people in the process. And I would say the cornerstone of the PREPARE program are these videos that model advanced care planning behavior. I will not bore you with all of the behavior change and social cognitive theories that went into creating PREPARE, but it really is sort of focused on how to, showing people how to do something, not just saying, hey, you really should choose a surrogate decision maker, but showing people how they can have that conversation. So how to ask somebody to be a decision maker, how to talk with family and friends, how to ask clinicians questions. And as people are going through PREPARE, they're answering questions about themselves. And this will be, can be printed out in a summary of their wishes, again, in sort of large font and fifth grade reading level. And if people are ready, it can be auto-populated onto an advanced directive. So I just want to quickly talk about 6 development tips for eHealth tools for older adults. This is what I'm going to be presenting here will be, it's in press, it's currently embargoed, and as soon as it is published, I will let you know. But one is to develop a clear objectives and a conceptual framework. So what is the gap you're trying to fill, and what are the things that you're trying to sort of accomplish? And I just put this reference here in case people want to go back and look at our sort of conceptual model, again, which is really focused on behavior change and social cognitive behavioral theory. And this gets back to that co-creation with community. This something called the cultural adaptation model. And so I can tell you that every time that I thought I had an amazing, great idea, and then I take it back to the community, I realized very quickly that it's not meeting the community's needs. And so every single product that we've created and PREPARE is a sort of slow, methodical process. We get community input first, we do translation, we get more community input, we do user testing, we'll do more translation, we get more community input, we do more user testing before we create the final product. And this really is a co-creation collaboration. You want to optimize the design and layout for accessibility and ease of use. This is just a picture from screen grab from one of the things in the one of the web pages in PREPARE, and you can see some things like the ability to switch to a different language, that there's play talking or speak aloud narration, there's closed captioning, and in terms of the design, making sure it's at a 5th grade level, that we're using short sentences and white space with key content that's first on the page, and the use of multimedia videos and large text with high contrast. You want to use simple navigation to address limited computer literacy. So things like showing a progress bar so people can know where they are, and then these big buttons like the next button. And this is particularly important for older adults that needed what we call a linear option for more passive users who just want to click next through the program. And for people who are a little bit more savvy, we have this non-linear menu option because we realized that we needed to have both for different types of users. Using actionable information to enhance behavior change. So using a summary of my wishes, which I showed you, and some action plans so people can make plans to do something, showing how-to content, see how, see why or see how to do something. And again, these videos that model behaviors. And then providing written materials that align with the eHealth tool. I can tell you, because we started our advanced directives, we created them first and then PREPARE second. When we tried to put them together, they didn't look the same. We weren't using the same colors and things, and that confused people. So we went back and revamped everything so everything is aligned. And let me tell you a little bit about the evidence before we end by talking about some practical tips. So we've now conducted 2 large randomized control trials with over 1,400 English and Spanish speaking patients. And when we think about advanced care planning, particularly in the clinical environment, I put that little picture of the pillars down there below just to remind you that there's many stakeholders: patients, surrogates, community, clinicians, health systems, and policy. And in the clinical environment, oftentimes interventions are focused on a clinician or facilitator, or it's focused on the healthcare system in terms of updating the EHR, and also providing patients information. And in these trials, what we really wanted to know is how much bang for our buck could we get if all we did was provide patients our easy to read, prepare for your care materials, and did nothing on the clinician side and nothing on the EHR side, knowing that a fully functional program would need all of those things. But again, knowing that people are strapped and health systems are strapped, how much bang for your buck could you get by trying to empower patients? So in our trials, one group got our easy to read advanced directive, and the other group got the easy to read advanced directive plus the prepare for your care program. And some people have asked, well, why didn't you have a control group? And we really felt like it wasn't ethical to not give everybody some form of advanced care planning. So everybody got something. Our patient group was very diverse. So there was about 45% of people who reported that they were Spanish speaking, and about 40% had limited health literacy. I can tell you that many people, I think more like 50%, reported that they had never used a computer before. So we thankfully found that PREPARE increases engagement in advanced care planning and documentation. So at the end of the study at 12 months, 98% of people reported that they engaged in some form of advanced care planning. And when we went back to and started digging through people's medical records, we found that we were able to increase advanced care planning documentation from 8.5% at baseline to 43%. And again, this is without any clinician or health system interventions. I think the results that I'm most sort of excited about is that we also found that PREPARE empowers people to speak up. So in these trials, we were able to audio record about 400 clinic visits in the week after people received this intervention. And we found that people who were randomized to the PREPARE arm versus the advanced directive only arm had a 46% higher empowerment to speak up about advanced care planning during those clinic visits. I'm just going to tell you a little bit about our dissemination research, because some of these things may be pertinent to what you're doing, and people can always email me afterwards to learn a little bit more. We've been doing a lot of outreach to the community. We've had about 400,000 unique users in 115 countries. And not surprisingly, during COVID, we've had sort of 5 times the increase in use. We've done several studies on group medical visits using the PREPARE movies. And what I mean by that is that people can go through PREPARE in an interactive way, but we also created movies just for all of those steps. So there's a step 1 movie that will just talk all the information to you. Step 2 movie, same thing. And we use those movies in medical visits. And we wanted to make sure that there was minimal facilitation for a facilitator, because all of the advanced care planning information is in the movies. And we did this pre to post study in 1 week, and we showed that surrogate designation increased from 48 to 85%. And in 1 week, we're able to increase AD form completion from 9 to 24%. And I'll tell you a little bit more about the group visits and movie events in a little bit. We've also used the movie toolkits, which we have in senior centers. And again, the people who were facilitating this in senior centers had never talked about advanced care planning before and had no prior training, and were able to use our movie toolkit. And 100% of the facilitators and the seniors rated the information as easy to understand. 93% of seniors said that they were ready to answer questions about their preferences, and 97% would recommend the session to someone else. We've also worked with our local Department of Disability and Aging and created toolkits for in-home supportive services providers and for case managers, which are also on our website. In these studies, we found that the case manager said that these toolkits, that 100% of them increased their confidence. 100% reported that the toolkit was easy to use and they would recommend it. And when we talked to clients, 100% said they had increased readiness to do advanced care planning. The information was easy to understand, and 92% would recommend using the toolkit with other case managers. We're also in the middle of a PCORI Capacity Engagement Award. PCORI is Patient-Centered Outcomes Research Institute. In Washington State, we partnered with Honoring Choices Pacific Northwest with really the goal to get advanced care planning out to rural and Spanish-speaking populations. And I'm happy to talk with you more about that. And for any of you who are maybe doing large system-based, population-based work, we also have another PCORI grant. It's a large grant in collaboration with UCLA, UCSF, and UC Irvine. This includes 50 clinics and about 20,000 patients who are 65 years of age and older with serious illness, who are randomized to these 3 different arms of the advanced directive only, an advanced directive plus prepare, and then also the use of a navigator. And this includes things like automated Epic MyChart messages and automated mailing. And again, I'm happy to talk with people about that if they're interested. And so now we'll end with just some practical tips and save time for questions. So we've talked about that there are multiple stakeholders. So there's multiple different kinds of tools on Prepare to try to help out. And people will ask me, well, who can use Prepare? And so the target really are ethnically, culturally, and linguistically diverse older adults. Anyone, we've tried to create the material so that anyone can deliver it, even people like librarians and people who run senior centers who maybe have no prior experience. And again, the training is minimal. So all the advanced care planning information is already included in our toolkits and websites. So we have multiple things, which I'll tell you about. If people want to go to prepare for your care right now, even as I'm talking, you can find these tools by just clicking on other tools in the menu. And this is what that page looks like. So this is Prepare Tools for providers and organizations. And the tools that I'll just highlight here are, we have how to use the Prepare tools. So if you want to know, what do I do and how do I use these and how can I use this in my organization or in my clinical environment, we have information about that. There's a quick start guide or advanced directives, the pamphlets. We have easy to use scripts, which are very basic, as well as more in-depth toolkits. We have our movie event toolkits. And then for people who are interested in research or quality improvement, we have a validated 4-item advanced care planning engagement survey. And all of these things are free and on our website. So the quick start guide, we found that for our older adults who might not be computer savvy, that this has really helped them so that they know how to click into the program, because once they click in, as I was showing you, there's a sort of linear process where they just have to keep clicking next. And so we've tried to make it really easy for people to get into the program. Our advanced directives, which you can get right off of the homepage. Again, just to remind you, they're easy to read. They're for all US states in English and Spanish, and including in New York, they're in Chinese. There's a growing number of languages. We have 11 in California, and like I said, this is growing in other states and for people who want to partner with us. So if there are other languages that you're interested in, let us know, and we can collaborate on that together. I think the thing to know is that as people are going through the prepare steps, it will pre-populate the advanced directive. So in New York right now, if people go through and they answer their questions, if they're ready, it will pre-populate the advanced directive, which they can then download and print for the state. And for people who just want to come to prepare and they don't want to go through the steps, they just want to go straight to the advanced directive, we actually created a guided advanced directive step that will walk them through each page of the advanced directive. And if they need additional information, it will pop up things like additional videos and things to walk them through that process. There are pamphlets in English, Spanish, and Chinese, which are used to good clinical or good benefit in clinical environments to hand out to patients or at fairs or at senior centers. And then I was telling you about these group movie events. So again, prepare, each of the steps can be played like a full movie with no interactive components. It's just a movie. And we've created these toolkits if people are interested in putting on movie events, either in the community or in group medical visits. And we've actually found during the pandemic, just like some of these presentations that we've actually had more attendance in our group meetings through Zoom, even for older adults who might have difficulty. Their family has been like helping them get onto Zoom, and it's been actually a really great experience. Again, these simple scripts can be downloaded. We don't have time to go over them now, but really they were developed for anyone in any discipline, particularly, starting in COVID. So this is words that you can say to ask somebody about a surrogate, words that you can say to ask somebody about prior advanced directives, and then words that you can say to give them basic information about advanced care planning. As I said, there's sort of some more in-depth toolkits that also have scripts and the ability to start conversations and discuss the PREPARE tools. And I'll just end by saying that PREPARE is free to the public. And we also love donations, because that's one of the ways that we keep the lights on and keep PREPARE free to the public. And the other ways that we keep things free is that we just ask people that to please use the link to the PREPARE URL for online and print materials when sharing things with colleagues. So, and we also have in our how to use PREPARE guide, we ask people to use our kind of standardized description. So if you're gonna say have a website, you could say this is what PREPARE is and copy and paste that from the how-to guide and then use our URLs. And again, we ask that people forward the link instead of the actual PDFs to colleagues and patients, because we're constantly updating our materials, and that's a way for us to do quality control. And then we ask people that they, again, print materials from the PREPARE website. If people are interested, UCSF does have licenses available, because PREPARE, even though it's free, it's copyrighted through the UC Regents at UCSF. And so things that licenses are available for things like using the PREPARE materials or PDFs on other online platforms or in electronic health records. And anyone who wants to brand the materials, or maybe you're launching a quality improvement project and you want to sort of do some data reporting to see how well things are going. So with that, I will end, and it looks like we have a good 10 or 11 minutes for questions, and I'll go ahead and stop sharing my slides. But just to say, if anyone has any additional questions after today, feel free to reach out. And so I am excited to hear about your questions. So Lisa, what do you think is the best way?
Well, thank you so much. That was so interesting. I'm sure there's some questions. Karen just put in the chat that you can put your questions in the chat if you'd like. Go ahead. And as we wait for a couple to come in, I have a question for you. If somebody was going to do one of the movie events that you described in their community, is that something that has to be organized through you, like you're doing a screening, or is it something you can just do?
No, something like, and again, we tried to set things up so that anyone anywhere could do this, with the idea that all the information is in our toolkits. And because PREPARE and the movies are free online, as long as you have an internet connection, you can play those movies. So we've done things like, there was National Healthcare Decisions Week or day that was just back in April. And in San Francisco, when we weren't in a pandemic, an example is that we were doing these in libraries. So some, people would come and just do facilitation. Some of the librarians were doing it. People have used it in sort of, churches and senior centers, as I said. So no one needs to go through us. You can just download the toolkits right off the website and go for it.
Super. And if you're more comfortable just raising your hand or just unmuting yourself, we don't have so many people here that could be chaos. So if anybody's more comfortable doing that, Karen and I can keep our eye on that. No questions, really?
I have one, and I'm trying to type it in, but it's kind of long, if that's okay. I just really want to thank you for a great presentation and a really well thought out program. I was involved with creating Sharing Your Wishes here in Western and Central New York State, also based on the one we did locally in Tompkins County, where we are now, was based on the Respecting Choices model. And our website had videos, and we created our own materials and things, but you've gone beyond that, and you've reached out into all the states, and you're doing great studies and stuff. So thank you for that. The question that we ran into while we were doing ours, and I'm wondering if your state-specific healthcare proxy forms address the quirks that you might have in different states. And I don't know if it's still the situation, but when we were doing our work, New York State, for example, did not allow healthcare agents to make decisions about withdrawing artificial nutrition and hydration once it had been started, even if they were the appointed agent, without some kind of evidence that that was in fact the person's wishes. If somebody contested it, it needed to be in writing. So we actually made our forms have typed right in, my agent knows my wishes about artificial nutrition and hydration. That was sufficient to get around that. So I'm just wondering how you tailored this to all 50 states. It just seems like a huge job. And if little quirks like that are captured.
Yeah. So I don't know if you can see my brain like exploding. We have partnered, like I said, you know, we sustain ourselves through donations and grants, and we work really closely with UC Hastings School of Law. And they basically every year, multiple times a year, we have to do legal review for all 50 states, because the 80 laws change often. For example, right now, Indiana is completely revamping all the laws. Oregon just revamped all of their laws. I don't recall, to be honest, exactly where New York is, but I can tell you that we have spent a lot of time digging through all the legal stuff, working with our lawyers. And you can imagine, I'll tell you this, that we thought, oh, maybe we could create an easy to read advanced directive that would work for all 50 states. And you can't, you can't, because it's like, if this, then if this, then that. And from a health literacy standpoint, it just doesn't work. And so we realized, sadly for us, that we were going to have to make 50 different versions. And when you think about adding the language, like it's in English and Spanish for all of those states. The other thing that we do is that we partner with medical legal partnerships. So there's a National Medical Legal Partnership group. I don't know if people know about that, but they're great. And they work closely with clinical organizations. And so we'll pilot test basically anything. So say Indiana, like I said, is changing the law. We update our forms with our legal team. We send that to the medical legal partners in that state. They review it. We go back and forth. We show it to people, and then we publish it online. So, and just to say to your point, there are crazy, strange laws in many different states that we've got to kind of work around.
Yeah. Thank you for all that work. It just seems impossible. So I would encourage people to send you guys donations just to help cover that, because you're offering such a good service.
Thank you, Rebecca. There's a hand up, Owan. I think I'll let you ask your question. Then we have a couple in the chat that I'll get to after you. So you can unmute yourself.
Thank you so much. This is great presentations. And I have two part of the questions. The very first one could be, is there adaptation for people with disability or for their guardians in a way where they can also prep for their children with disability for this context? And then my second question could be, for similar of this, would you also consider doing this kind of training for a community who English is not their first language at all? So that, or another question aligned to that could be, what is your plan in terms of disseminating all of this great tool for the family who are not, who English is not their first language?
Yeah, great questions. I hope I answer them effectively. So in terms of disability, I wasn't sure exactly what you were getting at. I think we've made sure that our forms are reviewed by people who have different types of disabilities. And it was really important to people who, especially the disability community, that there was extra space where people could write their specific wishes, where a lot of forms don't sort of address those things. So we tried to include that in the forms. In terms of non-English speaking populations, so the PREPARE program is available in English and Spanish, and really was co-created with Spanish-speaking groups. All of our advanced directives, when they're translated into other languages, again, we co-create that with people who are, primarily of that language, that speak that language. We right now are really, we've had a lot of interest because Chinese is the second most common language in the US. And so we've had a lot of interest in updating the videos and things like that into Chinese. And it's really just a matter of funding. So we are actually talking to people and looking for funding right now. And I think that comes down to the translation of other materials too. It's really a funding issue. So we've partnered with other groups and foundations. So as I was saying earlier, if there is a particular language in your area that is of particular importance and there's a way to partner to sort of translate the forms or materials, we love that kind of collaboration. So just let us know.
Yeah, that's really great. If you don't mind sharing your email address, I will follow up because I'm leading the support group for the Vietnamese community in Massachusetts, and I'm running that support group for, we do have a weekly training as well. And the information like this is very important for my community. Vietnamese is also the fifth largest language in the state, in the US. So that might be another way for us to look into and see what else we can collaborate to.
I'm going to put you in touch too with another woman who is disseminating our PREPARE research in the Vietnamese community. And she has slides and things like that. So I will put you in touch, and I'm going to be sharing my slides, and my slides will have my email address. So yeah, please follow up.
Awesome. Thank you.
Thank you so much. This is the connections we love to see being made here. So next question is from Elizabeth Bergman, who's one of our gerontology department faculty members, and she is asking, what do you see as major next steps in advancing access to advanced care planning for diverse populations?
Yeah. Well, first, I would love if oral advanced directives were acceptable. And I know that there's a big group toward, push towards that, because many people are not going to sign their name on a dotted line on a form. They're just not going to do it. But they will have conversations with their family and friends, and they will have conversations with clinicians. And so I think a push towards that is really important. I think the other big thing that I'm seeing a big change and push for are sort of, there have been fits and starts with state registries and things like that to make sure that these materials are and these wishes can be found across different sites. I know New York has a eMost program, and California is thinking about theirs, and Massachusetts is thinking about theirs. And I think with some of the health information exchanges, just getting access to this information is incredibly important. So I think that that's also, a way to kind of help make sure that if you've talked to this provider over here, people can find that information. I will say as well, this terrible COVID-19 pandemic, like if you wanted to pretend that there weren't health disparities, you kind of can't turn a blind eye anymore. And so I think that I am seeing, health systems sort of step up to the plate in ways that they haven't before. And I think that that does give me hope that, there'll be some focus or at least some efforts to sort of continue to try to decrease health disparities in advanced care planning.
Okay, I think we have, thank you for that. I think we have these next two questions I'm going to sort of combine because they're about your website. And then I think we might have to move on and get Dr. Kinderman introduced. She made a comment, Dr. Ann Kinderman, who's our next speaker, about the registries are helpful for diverse populations where care can be fragmented. Thanks for including that, Rebecca. Could Rebecca, you clarify the reprint permission if our Office for the Aging newsletter wanted to include the Quick Start Guide, which outlines for people how to use your site? We could certainly include the website link and give all reference credit. And then someone else asked if they wanted to add a link to from your website to their website. Is that a licensing issue, or is that something they can just do?
Yeah, the using the URL links, no problem. So if it's on website, and like I said, if you're like, oh, I want to use this link, but I don't know how to talk about PREPARE. Again, if you go to that how to use PREPARE guide, you can literally just copy and paste the description so onto your website. And then in terms of the Quick Start Guide, absolutely feel free to use the Quick Start Guide, because again, that's how we want to get people in. I think some of our other materials like the advanced directives, the pamphlets, like that kind of thing. It's okay to print those and hand those out to people. But like sharing like PDFs of our materials, like through email or through a website, those things require a license. But I think for the quick start guide, this is a good thing. We can maybe update the website about this. It's okay to share that.
You're right, it was really slow.
Perfect. Thank you so much. We're getting a little feedback from people, so can everybody who's not a speaker make sure that their sound is muted unless you need to ask a question?
I picked out, I did spend some time, so you know that I looked at reviews and stuff. I did pick out and put in our part.
And it looks like it, yeah, there we go.
Yeah, I wasn't sure if she was asking a question. I think she was just became unmuted.
Well, I think like looking at the time, I know that I have to go, but I just have to say you are in for a treat because Anne is an amazing speaker and has awesome things to teach you. She's a really great colleague. It's good to see your face, Anne. And it was really nice to be with this group. And again, if anybody has any questions, just let me know.
Thank you so much, Dr. Sador. Thank you for your presentation today. It was really great. Nice to have you. Bye. Okay, so without further ado, we should get rolling with part 2 here. So Dr. Ann Kinderman is on already, and she's going to share her screen in a minute, but I just wanted to introduce her. She is going to talk to us about cultural and linguistic barriers in working with interpreters. Ann is an associate professor of medicine at UC of California, San Francisco School of Medicine, like Dr. Sador. She's the director of the Supportive and Palliative Care Service at San Francisco General Hospital, which she developed and founded. Her scholarly work has included developing a curriculum in palliative care interpreting for professional medical interpreters and expanding palliative care services in safety net health systems. Among her interests are palliative care, health services accessibility, health disparities, and socioeconomically marginalized groups. So I'm going to let you take it away, Dr. Kinderman. You go ahead and share your screen when you're ready.
Yep. All right. Can we
Oh, and sorry, same thing with Dr. Kinderman. If you have questions, put them in the chat. If it seems appropriate to interrupt, we will. Otherwise, we'll maybe hold them till the end, depending what they are. But we will mind the chat for you, okay?
Thank you very much. Appreciate that. Yeah, please do put in questions as we go. So excited to talk with you about this topic this morning. My objectives for this morning are to talk about some common challenges that health and social service professionals face when they're caring for seriously ill patients from different cultural backgrounds or when there is language discordance. We'll talk about the key challenges to effectively integrating interpreters in serious illness communication scenarios, and then give you some practical solutions for addressing those challenges. I have no significant financial relationships to disclose, but I do like to disclose that I do have a bias of coming from a safety net health system and give you a little background on that. So Zuckerberg San Francisco General, we added the Zuckerberg about 6 years ago. And yes, that is the Zuckerberg you know about. He gave us a large donation to help us put computers in the building that's centered in this, which is our new hospital. And it's a level 1 trauma center. We are the safety net provider for San Francisco. We provide about 80% of the charity care in the city. And just to give you a flavor of that, about a third of our inpatient hospital days are in uninsured patients. 42% of those people have Medicaid, and only 3% of our patients are commercially insured. And those are usually trauma patients that roll in because we're the highest level trauma center in the city. And then when they're stable, they go to their, commercially insured hospital system usually. We're the second most ethnically diverse medical center in the US, and we have about 140 languages that are spoken per month at San Francisco General. Just to give you a flavor of the patients that we take care of, generalizations are always really fraught, but I will say that our populations are different from what you'll find at most general not-for-profit community hospitals. So we take care of a large proportion of immigrant patients. So people who often English is not their first language. They may have limited education levels attained, limited health literacy, and there may be significant differences in their experience of healthcare coming from different cultures around what's expected in the system and of them and from providers. And then other populations that we take care of are largely people who I would consider socially marginalized. We have a oddly high proportion of people who we call unbefriended, who do not have surrogate health decision makers, medical decision makers in many cases, and don't have reliable caregivers. They may have significant mental health issues or substance use disorders, and they may have struggle with homelessness or marginal housing. And so I just wanted to highlight, as you can all see on Zoom, I am a white woman and I was raised in a relatively affluent suburb of Chicago. And so there are significant cultural and linguistic barriers that I face every day in taking care of my patients. So this is an everyday occurrence for me and a challenge that I really appreciate and learn from. And I don't want to just sort of say that this is this type of diversity is exclusive to safety net hospitals. And I want to give you some language around this that I'll be using throughout this presentation. So I'll use the phrase limited English proficiency, or LEP, in the slides. And that's actually a term that's defined by the US Census. It's defined as people who report that they speak English less than very well. And that's important for things like healthcare, because as you can imagine, if you speak English less than very well and you start thinking about the terminology that you need in healthcare encounters, it's really pretty high in many cases. This is something that is measured yearly across the US, and it's in the American Community Survey. The most recent one that we have data from is 2019, and that showed that across the entire US, 5% of households report limited English proficiency. But as you can see in the map on this slide, that is not evenly distributed. There are, in the dark blue areas, are where there is the highest proportion of people who report limited English proficiency. So I did, I'm not as familiar with New York outside of where I have family and friends in New York City, but I was looking at these areas where you see the darker blue, and I would be really curious to hear more about your experience and appreciate the question around the Vietnamese population that you guys are taking care of there. But just to say, we take care of a large proportion of limited English proficient patients. That's something that we track in our palliative care service. And it's about 35% of our patients in any given year who report limited English proficiency and need interpreters. So what do we know about advanced care planning in vulnerable patient populations? I'm sure that you are now very versed in this with Rebecca's talk, but just to highlight here again that low health literacy is associated with less advanced directive completion, and even if they complete advanced directives, less certainty about their choices. Rebecca herself has done a number of great studies at San Francisco General, and a number of years back, she did a study where different patients, different backgrounds, talked about their wishes in hypothetical scenarios in the future. And she found that Latinx patients and Asians were less certain than the white patients in that study when they chose their wishes in advance. And then a large Medicare beneficiary survey, when they talked to people who would have different levels of English proficiency and different racial ethnic backgrounds, they found that Spanish-speaking patients reported the lowest prevalence of having advanced care planning discussions among all these Medicare beneficiaries. So we know that there are disparities there. There's another interesting study that was done in the state of California specifically around what is the quality of end-of-life care that people receive? And this was a study that was done, a survey of people who had lost a loved one in the previous year. And they asked them a variety of questions. And so some of the questions that they asked were their wishes honored and followed at the end of life? And how good was the quality of care at the end of life? And they found in the study that if there was a language barrier, which is the blue bar, they were far less likely to report that their loved one received high quality end-of-life care, that their wishes were honored and followed. So language barriers make a difference. Sorry, I'm frozen here. There we go. We also can see an impact in terms of who gets hospice care. So just to walk you through this slide really quickly, the blue bars are the racial proportions of hospice and palliative medicine graduates in 2015. These are physicians. The 2018 census is in red, and then in green is the population, the racial ethnic background of people who received hospice care in 2017. And these are all the most recent data that we have information from that I could compare against. And you can see that the hospice population most clearly reflects not the US population, but actually the hospice and palliative medicine workforce. So you can see this in the African American community, you can see this in the Latinx community, and you can also interestingly see that there's a greater proportion of hospice and palliative medicine grads that identify as Asian American compared to the hospice population. So there'll be some interesting conversation we could have about that. I just wanted to go into a little depth in thinking about what does it feel like if you have language or cultural barriers and you're trying to access care, not from the face of the person we can see, in this case, the healthcare professional, but from the person who's receiving care. So thinking about this scene is one that is very evocative for me, and not from directly a patient that I took care of, but I have been in this scenario many times of someone who is acutely ill in the emergency department, and we have to make decisions really quickly. You think about that, if you're a person who is very sick, it's even harder to process information. And then if you have limited English proficiency, getting an in-person interpreter who you can see well and get the nonverbal cues, that's really hard. A lot of times what happens is someone who isn't necessarily a certified interpreter is brought in and sort of getting by in those situations. Providers are nervous about what's happening, and so they're asking about life and death decisions you may never have thought about, and they're very urgent about it, and you don't necessarily feel like you have the time to make that decision. And when they make decisions, people may have limited understanding of the implications and the choices that they're making, say around intubation or CPR. And these are some thoughts around what it's like to be someone coming from a different culture in the standard American hospital. I've heard these quotes around, you're taking too much blood from him. I've heard this from some of my Asian American patients who have this sense that, oh, my dad is weak because you're taking too much blood and you're sort of draining out his life force. And the providers get frustrated and say, well, we have to check his creatinine every day because he has kidney failure and we need to know whether he has dialysis. And so there's sort of this cultural clash. We have other patients who are very insistent, that in order to cope or to relax, they want to go outside to have a smoke, but that's against hospital policy. And they may have to be discharged against medical advice if they want to go outside for a smoke, which is not an unreasonable thing altogether, but just it doesn't fit into our model. People are disconnected from primary care and other trusted providers in the community when they're in the hospital. It's all new people usually. And then again, there are these communication barriers and access to interpreter services can be spotty. If you're a patient, what do you experience from providers? Well, a lot of cases you can have information overload, where there's medical jargon that's coming at you. You may have experience from different teams or different providers who are coming in to give you their input on the kidneys or cancer or diabetes or any number of things, and they might not all fit together. As professional healthcare professionals, we tend to focus more on treatment decisions and choices rather than values. And we know that patients tend to focus more on the big picture and on values in many cases. And if you're coming out of some other cultures, there can be a lot more focus on the healthcare professionals giving recommendations or even telling you what you're going to do, as opposed to the culture of the United States, which is focused on autonomy and really putting the decision in the hands of the patient or the surrogate decision maker. So what does this result in? What does this look like? Well, from a provider, if they keep trying to get this answer to a question around a specific healthcare decision, as if they're not getting an answer, they can seem impatient or pressuring, frustrated with not having an answer. They can be repetitive around, do you really want to be full code, that kind of thing. Anxious around not knowing or uncomfortable in the situation. And what it looks like from a provider perspective of the patient is they can seem quiet or disengaged. They might seem ambivalent, confused. They can't recall prior information. It's like you have the same conversation again and again. And they don't want to necessarily complete an advanced directive, even though we would love to have that in writing. So as Rebecca said, there are a lot of people who don't fill out legal advanced directive forms for a variety of reasons. So this really kind of comes up with this clash of cultures that we experience in the hospital when people are seriously ill. So I want to move forward, and please, of course, do put things, questions or thoughts or comments in the chat that we can talk about at the end of the talk. But I want to move into the middle section here where we really focus in on the challenges of communicating with limited English proficient patients and families. And this is an actual sign from San Francisco General on the wall, and it's in relatively small type. It's in just 2 other languages. These are the largest language groups that we have, English and Chinese. But if you can't read, this does not help you. So I just like to say that even though we do this a lot, we don't always do this perfectly. So I'm going to talk about 3 key challenges when you're working with interpreters in serious illness communication. And I will just say, I'm going to take it on faith. There's a whole nother talk we could do around the evidence base around why it's important to use professional interpreters as opposed to people who are not trained interpreters or family or friends. And we could talk about that briefly in the question and answer if you'd like to, but suffice it to say there's a lot of evidence around that. But when you're working with interpreters, what are the challenges? Well, one is that we lose control over the message that's being conveyed because you're not speaking the same language. Integrating an outsider into the healthcare community service team who you don't necessarily work with or know, and we don't know how to work effectively together and how to support interpreters adequately given the emotional weightiness that can come up in these talks. And lastly, just the practical reality of access to interpreter services. So we'll go through each of these one by one. So first, I call this the lost in translation challenge. And I will say as a palliative medicine specialist that in my field, we consider ourselves to be experts in communication. And it can feel very scary when you lose control over that and how the words are being said. We choose our words very carefully. And so I like to give as an example, what are the words used when someone dies? And so in healthcare, you may hear anything from pass away or softer euphemisms to die, which is used, I would say, strategically in certain situations to communicate the seriousness of what it is happening or has happened. And sometimes in healthcare, unfortunately, you still hear people use the word expire. I hope that that is not common practice where you all are. And I had a colleague who said, milk expires, people die. So I hope that's not used, but each of those words has a different tone or a different feeling to it that we're trying to communicate. And so thinking about the challenge of coming up with that word in a different language. So when we care for patients who have limited English proficiency, the person acting as the interpreter has control over the message in both directions. And I would say as control freaks in healthcare, we generally think about our message being conveyed faithfully, but we also miss what the patient or the family is saying in a lot of situations. So I wanted to just go through a few studies about this, kind of the issues with working with interpreters and the message. So there's a study going back a while back in the ICU looking at family meetings, and they found that over half of them had some sort of alteration in meaning. And those alterations were things like adding bits of information, leaving things out, changing, and editorializing on top of what the providers were saying. And unfortunately, over 3/4 of those alterations were considered clinically significant, and most of those clinically significant alterations were judged to have a negative impact on communication. So this happens. and looking at then a population with children in the pediatric ICU with Spanish language family meetings, again, over half of them had these additions, omissions, substitutions, editorializations, answering in advance for the patient or clinician, making confessions, and patient advocacy. So there are different roles of interpreters, which we'll get into. And one thing that I want you to hold on to, and I'll repeat this later, is that they found that when providers were using more than 20 words at a time, they were more likely to have these alterations. So thinking about that as a magic number. A couple more studies. So they did a small cross-sectional qualitative study interviewing providers and interpreters regarding control over their interactions. And when they talked to the interpreters, they said that they tried to foster direct communication between the patient and the provider, though these techniques were not always well received by the provider. So thinking like they're trying to facilitate direct communication with the patient and the provider, but the provider might be looking at the interpreter or speaking in third person or other things that made it harder to make that connection happen. And interpreters actually reported directly that they would change providers' words or refuse to interpret things what they perceived to be culturally inappropriate. For example, they would use the word specifically leukemia instead of cancer because cancer may have had a weightier tone or a more negative connotation in that other language. And most providers said that they were comfortable with the interpreters giving suggestions and altering things so long as those alterations were reported and we had open dialogue about that. So I think that's important. And just lastly, an Australian study that was interesting because it had, I think, a probably real life, unfortunately, situation where there was professional interpreters and informal interpreters, so either staff or family members. And they showed that there were many examples of both professional and family interpreters changing the doctor's message, usually to soften the news and occasionally to hide poor prognosis completely. So I just want to, this is one of the things to say around the importance of having good communication with your interpreters and to rely on professional interpreters to convey your message. So the second key challenge is what I call the invisible team member. So when you have a high functioning interdisciplinary team, those teams are generally intentional about creating trust and promoting self-care for members of the team, particularly in hospice and palliative medicine. And when you introduce an interpreter, that person may feel like they're addressed simply as a language conduit rather than as a key member who's included in the team. And I'll just say that, you know, for me, when I know that there's a very intense family meeting coming up that day, I can emotionally prepare for it. But that interpreter in many cases has no idea, and they may have been doing a very mundane conversation just before this, and then all of a sudden they're in a life or death conversation, which is hard to adjust to quickly. And the last challenge, which is, I know, a big one, is access to interpreter services. And we know just overall that there are not enough healthcare interpreters, and there's roughly 1 per 800 limited English proficient Americans. These services are costly. In-person interpreters can be north of $26 an hour. And there are these language line services that will quote rates like $1.50 a minute, but actually if you are a smaller volume client, the rates can be much higher than that. And if you think about, for example, as a hospice provider, if you have $150 a day to take care of someone and you have a 30-minute language line conversation, you've just blown your whole day's budget with just language services. In-person interpreters may have limited hours and work part-time in another capacity, so they're not always available. And you may not have interpreter support for all languages. And I will tell you, just real-world example, I take care of a woman in my clinic panel who is Samoan speaking, and I cannot guarantee that I can get a Samoan interpreter for her every time that I need one. And even when I ask for it 24 hours in advance. So there are just realities of we can't always provide what we know is the best care in these situations. All right, so I want to talk not just about the bad news or the challenges, but really talk about the best practices in working with interpreters and with limited English proficient patients. So my suggested solutions really, I think you need to think about this on multiple levels. So I think we usually think mostly about the individual patient interactions that we have with our patients or our clients, but really that can only go so far. And so I think that we really need to think also about what can you do in your healthcare system, your agency, your program, and then think really broadly also about advocacy for state or nationwide interventions. So I'm going to focus here because I think the thing that we have in more our day-to-day interactions is how do we interact with individual limited English proficient patients and families. So some best practices that I would encourage you is one, as I've said, using professional interpreters in any situation that you can when you're communicating with someone who has limited English proficiency. And when you're communicating with interpreters, some best practices to use first person. So I act as if there is no language barrier. So I speak to my patient as if I'm speaking to them in English. What would you like for your healthcare, as opposed to what would she like for her healthcare? Because if you think about it, it's another level of difficulty if they have to change the tense and the pronoun and things like that, and rather than just direct interpretation. So I encourage looking at the patient as opposed to the interpreter, even though that can seem awkward at first because the person doesn't understand you directly. But I will tell you that if you do that and you're really making eye contact, I think that that helps to really build rapport with people, and people will respond. Again, use short phrases, and I encourage you to think about 20 words or less to try to improve the likelihood of kind of avoiding those alterations in meaning. And check for patient understanding frequently. So I would say at least every 2 to 3 bullet points of information to sort of go, okay, let's take a pause. Tell me what you've heard. Tell me what questions you have. And if you get into a situation where there's like a back and forth and back and forth and back and forth and back and forth with an interpreter and a patient, I will actually call timeout and say, like, interpreter, I noticed that there's a lot of exchange here, and it's really important for me to hear everything that's going on. Can you just pause where you're at and tell me what's going on? And if you are trying to address the interpreter, I encourage you to start with interpreter, because that way the person will know that you're trying to get their attention as opposed to speaking again to the patient. So use those lags that you have between when your message is being conveyed and the patient's response is being conveyed. So sitting down, leveraging that time to make eye contact, nod your head, use those nonverbal cues. I encourage people to use the words that you're comfortable with, though I will say, as an asterisk there, I know it is difficult, but trying to avoid euphemisms, which is so common in our language, but they're really unique to English and even American English in a lot of cases. And it really depends on your interpreter about whether they're familiar with that euphemism and whether they can come up with an equivalent in another language. So like, hopefully we're not using things like kick the bucket or buy the farm or things like that, but those are just examples of things that we use as colloquialisms in English to try to soften things, or like get across the finish line, things like that. So try to think about how to say things without jargon, but without euphemisms to make it easier on your interpreters. And just as a note here, that interpreters themselves have a wide range of English vocabulary and proficiency, and that's something that will affect those conversations. And ideally, if you get to know interpreters better, if you have them working with you directly, you can get a better sense of that. And since I don't communicate in, say, Cantonese, though a lot of my patients do, I can't monitor what's being said in different directions. But I will tell you that I can now that I've listened for it, I can hear if there's hesitation or stumbling over words, or there's this lots of back and forth without interpretation. Those are some of my cues that things may not be being conveyed in an appropriate way. And so that's when I may call a timeout and ask the interpreter what's going on and if I can assist with terminology or anything. So before an interaction, this comes through in all of the best practices in palliative care, working with interpreters, is to try to pre-meet before conversations. So it doesn't have to be forever, just a minute or two to talk about what you're going to talk about. So number one, I ask my interpreters, does the person know the patient? This is probably different if you're using one of the language line services, but if it's an interpreter that you work with, does this person know the patient? And I usually like to ask, especially if it's in a smaller language group, does the interpreter know the patient personally or professionally? Because there can be significant confidentiality issues in some of these smaller communities where this person knows the patient socially, and all of a sudden you're coming into protected, very sensitive health information. So sometimes you can't avoid this because you don't have, 20 Samoan interpreters to pick from, but it's something to be explicit about in the conversation. And if there's the person knows the patient, what has or has not worked well in the past. This is great to elicit from the interpreter or share if you've had previous contact with the family so that you know they're on the same page with you. Are there cultural issues we should be aware of, talking about artificial nutrition or hospice or other things like that? And you talk about the agenda and anticipated terminology coming up with terms in serious illness and end-of-life care. After the meeting, I also encourage taking just a minute to ask the interpreter about what went well or what went badly. Were there messages that were lost? Were there nonverbal cues or side conversations, especially in family meetings, that the interpreter noticed but did not convey? And I will say, just yesterday with this Samoan interpreter, I had a patient, she's a patient who has interstitial lung disease, but she will always use the term asthma. And so I explicitly talked with this interpreter at the end of the conversation and said, she uses this word asthma. Is there another word or another way of saying interstitial lung disease in Samoan? And what I learned, brand new for me, is that this is asthma sort of used as a catch-all for basically what people will call like shortness of breath or lung disease. And it's very common that that's how they understand it. But for me, asthma is a really common illness that people don't usually need a lung transplant for. And my patient is being recommended for lung transplant. So there's a lot of difficulty when my patient is sort of saying, I don't understand why I'm so sick, because asthma is not that big a deal for a lot of people. So I also asked, just back to the interpreter debriefing, is how's the interpreter doing? And encouraging them to pause if needed, especially if the emotions have come up for the interpreter during the conversation. And I will say that for me, working with in-person interpreters and staff interpreters at San Francisco General, these don't just provide practical solutions, they also foster an atmosphere of mutual respect with the interpreter and have taught me so much and have really contributed to better conversations over time. Some additional ways to improve individual patient interactions is to leverage the interpreter's skill and experience beyond interpreting specific words and to improve your own cultural competence. So leveraging the interpreter's skills. So I think it's important to note that not every interpreter certainly is a first-generation immigrant, but many of them are. And for those who grew up in another culture, they may be coming out of a context in which physicians are highly respected and are not to be questioned. So for me as a physician, I really need to go out of my way to value and respect them and say, your information and your expertise is really valuable to me. And so please tell me what I missed or what I could do better, because they won't necessarily automatically give that to me. And I will say that often we interpreters are really seen as these message converters, but really can and should in some cases adopt more nuanced roles as needed. And there's a visual for this, which was created by a colleague or used initially by a colleague of mine, and a model that was from Healthy House Within, around these different, this is sort of like a ladder, you can imagine, where at the lower levels, someone is trained or certified in interpretation, and they're trained to overcome these language barriers. And that's where they're converting the message back and forth from a healthcare professional to the patient with limited English proficiency. But then there's additional layers of sort of what is called a register barrier. So that's someone who speaks with a vocabulary of the New York Times versus someone who speaks with a vocabulary of a fifth grader reading. So recognizing that there's different vocabulary to change the message so that it is coming across clearly to both parties. And then on top of that, there are cultural barriers. So this is not coming across culturally. And so that's where an interpreter can come in as a cultural clarifier. And I'll give you an example of this a little bit later. And then lastly, there are systemic barriers that can come up. And so an example of this is sort of saying an interpreter is working with one provider and they learn about this amazing peer advocacy program that works with Spanish language speakers. They go to a next interaction with a different patient and a different provider who doesn't know about that service. So an interpreter could sort of say, pause, excuse me, Dr. Kinderman, I wanted to let you know, I just heard about this resource and I think it might be appropriate for the patient if I can tell you about it. So there are these different layers that an interpreter can serve as, and the idea is that they're mostly at that bottom layer of message converter, but they can, and I think we can access these other incredible ways that they can help patients and help us. It's important to think about also how to improve your own cultural competency. That's sort of paired or in opposition to sometimes this idea around cultural humility. So for me to say, even though I have worked with many patients who are from the Chinese community, I certainly don't approach every conversation with a Chinese patient assuming that they think or feel certain things, that this is an individual who needs to be approached as an individual. But there are certain contexts that I take in my cultural competency around these are things that are more prevalent in this community as opposed to others. I will highlight this website, ethnomed.org. It's a great resource for thinking about different cultures and particularly things around serious illness. I have a couple of references here on some articles. So you'll have these slides and there are more resources at the end, but just to flag them here. And I'll say working with local hospice providers and agencies that work with specific communities can really help them, help you learn more about these populations. So then thinking on this bigger level around hospital or agency-wide interventions, offering training for interpreters and working with serious illness. The palliative medicine team can potentially provide didactics on site or do off-site continuing education opportunities for interpreters. I think it's really critical to build relationships with interpreters so that they feel included on the team. So offering these support and debriefing opportunities beyond the sort of 1-minute debriefing, but sort of saying, how is the impact of these conversations on you? How do you think about these conversations? And inviting and helping them to participate in self-care and reflection, I think is great. There are some great palliative care educational opportunities for interpreters. So I helped to develop this online curriculum called Interpreting and Palliative Care that interpreters can access on demand for $35 and go through our curriculum in palliative care. I think it's great for palliative care teams to invite interpreters to case conferences and palliative care related conferences like Grand Rounds. Getting hospice volunteer training for your interpreters to kind of let them understand what hospice is like, inviting them to the Hospice and Palliative Medicine Association meetings. There's end-of-life nursing education consortium trainings, pulse trainings, and then specific advocacy groups that help to train healthcare professionals like the Chinese American Coalition for Compassionate Care. I would say getting to know your interpreters is when you have on-site or interpreters that work with your agency is critical. And you'll notice that some will feel comfortable with end-of-life conversations and others will not. And this may be, I will say, goes along with if you have people on your team who are fluent and bilingual in other languages and they help mediate these conversations, they may or may not feel comfortable with these conversations. Excuse me. And so I would partner with your interpreter services director and consider identifying specific interpreters for serious illness conversations, and think about having less experienced or less comfortable interpreters shadow those who are more comfortable. And just having day-to-day conversations with your interpreters will really give you a sense of their English proficiency and their personal stories. And the example that I highlight here is an interpreter that we worked with at San Francisco General, who was one of our Chinese interpreters. And we had a lot of difficulty with him early on, where he would refuse to interpret certain things. He would refuse to sit down. He would refuse to do a number of things that didn't feel professional to us. And when we talked with our director of interpreter services about this, what we learned is that he is a trained and practicing surgeon in China. And so, you know, it doesn't change the fact that his role is as an interpreter here and needs to act in that role now, but it gave me more empathy for him because I thought about all of my surgical colleagues and what it would be like if I took them to another country and asked them to interpret for me. Would they have strong feelings about how to convey serious illness to patients and bad news? For sure. For sure, they would have strong opinions on that. So that context is important. I encourage interpreters to attend to their own self-care. So ad hoc support for after difficult interactions and offering these support groups to discuss difficult cases. In palliative care, we have sometimes yearly remembrance activities or celebrations. I think it's a great idea to invite interpreters to those. On a larger level, kind of advocacy, education opportunities for interpreters, there is certification of healthcare interpreters now, and there are online or regional training opportunities to improve their skills in interpreting. And I would say, you know, particularly if you're working consistently with certain language agencies that you're paying for these services, demanding that there's a certain level of quality is important. And there are these growing kind of solutions around more and more remote interpreting services and pooling interpreter services so that you can have more on-demand access than has been traditionally available. But I will just say that the access issue is a huge one and is a big topic unto itself that I unfortunately don't have easy solutions for, but I'm happy to chat about. I will just say in the last few minutes here that just to say that I've been talking a lot about language and about race or ethnicity, but culture is really way beyond that. And these are just a small handful of different cultures that we think about, people who may be homeless or who have served in the military, people who have different education levels, who have been incarcerated, their sexual orientation or their marital status. These are all different cultures that have implications for understanding each other and can present barriers when people are trying to access care and when they're dealing with serious illness. And my big example of this, again, in working with an interpreter is that something as basic as thinking about what color do you associate with death or mourning is actually different in different cultures. So in the US, we think of death or mourning as black, typically. But if you look in a lot of Eastern cultures, it's actually the opposite. It's white that people wear to funerals and other kind of death and mourning. In Mexico, mourning associated with yellow, brown in India. In Brazil, purple is often worn to funerals and is actually by some kind of sub-communities in Brazil, if you wear purple outside of the death and mourning context, it's inappropriate. And then in Turkey and in some countries in Africa, red is associated with mourning and death. So my story associated with this is that we had a patient who was a Korean American woman who was very sick in the intensive care unit. And what the nurses told us was that she would get very agitated whenever her sheets were changed and they couldn't understand what was going on. And it was actually an interpreter acting in a sort of level around cultural clarifier saying, you know, I wonder whether that's because the sheets are white and that is associated with death in our culture. And so every time her sheets are changed, she's thinking about that, or she's thinking about her coffin or something like that. And that's something that's fixable. We have surgical towels, we have other things that that can help calm someone down. So so it's important to think about what are we missing in these different layers in our interactions with patients, and how can other people help us understand better. So how do we, some additional sort of higher level innovations to promote equal access and consistent quality care? And I'm going to speak to two kind of quickly here as we wrap things up. One is community health workers and two, cultural mediators. So thinking about community health workers in this area of serious illness and palliative care, community health worker is used somewhat interchangeably with lay health worker or navigator, similar skill set and role, though I will say the terms are used intentionally and differently. So I'm not sort of trying to say that it's all the same, because some people feel strongly about this, but I will just say the skill set and what they do is similar across these different terms. They're often selected as a peer or a person who can bridge cultural and or linguistic divides between the patient and the palliative care team or the healthcare team. They tend to have a wide range of responsibilities and roles. So there are a couple of nice studies that have been done. One was a focused advanced care planning intervention at the Palo Alto VA, where this was cancer patients and focused specifically on advanced care planning. And what they found is having a peer helped to shift end-of-life utilization, so less use of the hospital and the ED as people approach the end of life. There was more advanced care planning documentation, and actually increased satisfaction with care by the oncologist because of this other person's interaction. There was another nice program in the University of Colorado where these community health workers focused on symptoms, advanced care planning, and hospice conversations, focusing on Latinx cancer patients. And they found better documentation of advanced care planning and pain, and there was more receptivity to hospice compared to the control group. There's a really cool program at the Harborview Medical Center, which is a safety net hospital in Seattle, where they have a cultural mediator program that's supported by the Interpreter Services Department. These mediators provide services similar to community health workers or navigators, plus they have professional interpreter services and then intentional mediation of cultural issues. So those type of things that we are missing, the cultural cues and the mistrust issues that come up across patients and providers in the healthcare system, they really help to bridge those. They also do dedicated education efforts, both for providers to understand the culture and also out to the community, so to help them understand the issues that come up around serious illness or end of life. And I have a couple of articles here around cultural mediators if you have interest in looking at that further. So just some strengths of community health workers and mediators: they may be able to address mistrust. They reduce disparities in advanced care planning and symptom management. They facilitate communication, again, in both directions. They can convey complicated medical issues in a cultural context and bridge gaps in the community and healthcare system. Hopefully build linguistic and cultural competence in hospice and palliative medicine and healthcare teams. And hopefully these people can also one day, kind of help us build up the diversity within our field in hospice and palliative medicine and in healthcare in general. So just a few take-home points before we wrap up and go to question and answers. So linguistic and cultural barriers make it harder for people who want to make their wishes known to get the care that they want. There are a bunch of best practices in communicating with limited English proficient patients that can help improve the quality of these conversations. And I think it's really nice to think about what larger interventions your system or your community needs to overcome these type of barriers. Is that mediators or community health workers? Is that kind of more attention to the language services that you're using, more written materials or visuals to help people, and what structural changes might be necessary to help make care more accessible? I just want to acknowledge some colleagues that have contributed to this work. My counterpart at San Francisco General, Heather Harris, and Nora Gonzalez, a social worker from Colorado who originally helped put together this presentation. The Healthcare Interpreter Network, who's helped to promote this education for healthcare interpreters, and Harborview Medical Center colleagues who are part of the Cultural Mediator program. So with that, I would love to move on to questions and discussion. I will just say that you will have the slides and there's some resources at the end of them. So with that, I know that there has been a bunch of activity in the chat, and I will just say that I have trouble multitasking. So I look to our wonderful facilitators to help sort through the questions and comments.
Yeah, let me thank you so much. That was so much good information. Wow. That stuff about the colors was really, that was new to me. Wow, that's really fascinating. Yeah, so let's see. A couple people put some links and resources in the chat too, so maybe people can just, click on those as they see fit. let's see, just a couple comments. Not all languages can obtain medical certification, sadly, including Vietnamese. Next one is a question. What steps can be done to ensure more professional interpreters are available? How can we better advocate to legislate to better support our underserved health facilities and rural areas?
Yeah, I think this is great. I mean, so I will say one thing that is a bit fraught is a number of years back, sort of somewhere around, I want to say like 2010, there's sort of these competing organizations around certification of interpreters. And so there were like, you know, there wasn't one national understanding of like a single certification, like the American Board of Internal Medicine, to say you're qualified to do internal medicine or to do hospice and palliative care. So it's a little bit tricky around what that is, and it's not required by every agency. So I think that's some of the thing too, is for us, I think as consumers, our health systems to demand that, to say we want our interpreters to be certified and that should be a standard. I think the power of that, as opposed to legislation, may be a faster way to get at that.
Does that answer your question, Barbara? Let's see, how do we better? Okay, let's see. Another question, what about virtual/telephone interpreter services? You touched on that a little bit, and this question came in early on, so I don't know if you have anything else to say about that.
Yeah, so I will just say I acknowledge that that is the way that a lot of interpreter services is moving, just because of the access issue and expense. We certainly don't, like in my case of the Samoan interpreter, we don't have on-site Samoan interpreters, so we use Language Line for that. And so I will say that you just have to, I think it can be tricky. Most of my interactions with interpreters remotely is by phone as opposed to video. And so what I'll say is you can still do the quick pre-meet and debrief. I would say that it's a little bit easier for me to do that in person with people who expect it. And when you're having that interaction, that face-to-face interaction. But I will say sort of like, while I'm letting the interpreter know this is the patient's name, medical record number, you know, where I'm calling from, all of that, to pause and just say, interpreter, I want to give you a little bit of context on this conversation that we're about to have, to let you know. And then in the case of the Samoan interpreter, I specifically said at the end of the conversation, interpreter, can you stay on for an additional minute just so I can ask you some questions about the interaction and things I may have missed. So then she disconnected the call, and then we had a conversation around that. So you can still do the pre-post and still have the discussions around vocabulary and other things. Though I will say it doesn't feel as fluid or as easy as it does in person.
This next one is a comment, but it's related. For virtual phone interpreter services, it requires a strong internet connection. The minus part of virtual and phone interpreters that you won't be able to see nonverbal language in your patients, which
yeah, no, it's real. It's there. I mean, you know, the over half of communication is nonverbal. So you do miss, I'm not going to pretend that it's the same, but it is certainly better than not having an interpreter.
Yeah. And then another question, any means to allow non-English speaking patients to evaluate an interpreter's competency, in parens, allow hospital understand if interpreters used are effective and culturally sensitive?
Ooh, that's great. I will say that there are some times where if I'm noticing or I'm clued into that after an interpreter is gone, if I have another interaction with a patient, I will say when this comes up for me mostly is when there's another family member who has greater English proficiency, who can monitor the conversation and sort of hear what I'm saying in English and understand it. And sometimes if they're particularly strong advocates, they'll jump in and sort of say, no, that's not exactly what she said, or, you know, whatever, that kind of thing, which can really rattle the interpreter, understandably. But I will ask, especially if something like that comes up, I will specifically talk with that family member and say, like, it's very important to me that we have really good communication with your family and your mom. And I noticed that you jumped in. Do you have any feedback for us around this interpreter? Because we take that very seriously. We want to provide high quality interpreter services. And I will also say, I try to take note when they're particularly great interpreters too, when they're really good, very professional in their role, and highlight that and praise them, because most people do negative Yelp reviews as opposed to great ones, right? So.
Yes, of course. Let's see, thank you for that. Great advice and great just things to think about. Couple comments. Really appreciate addressing organizational health and cultural literacy in context with personal health literacy and interpreters. Somebody said, please be mindful of using red pen for Asian patients to sign off paperwork, Chinese, Korean, or Vietnamese. Is that something I don't know what that is? I don't work in healthcare.
I would love for whoever put in that comment to tell me more. I haven't heard that before.
That is Owen. Do you want to unmute yourself and explain what that is?
Owen?
Sure.
Owen?
Yeah, sure, definitely. Yeah, because sometimes, especially for me, for Vietnamese, I myself a Vietnamese community member. So when doctors or school district expect me to sign off paperwork using a red pen, I would not want to do that, because usually for us, when you red, that associated with mourning and things. So if you expect me to sign off paperwork in red, and that's just like a death sentence for us that we associated with, that we just don't want to have it. So both for school and medical field is also something that we be mindful of.
Thank
and
you.
I know Korean and Chinese also the same thing. So
that's so interesting. Again, back to those colors and what they mean to people.
Right. Yeah. And then number 4 too, also associated with death for Chinese. So.
Okay.
Yes. Yeah. And there's certain numbers around sort of like people who, Chinese community who want to have their babies. 8 is a lucky number. So like, having, babies coming in August, August 8th is like great, so all of these things. I've had patients who don't want to withdraw life support on some of those auspicious days. So these are really important things to be thinking about and help people make decisions.
Okay, I know we're running short on time, so I want to see if I can fit a rest of these. This is more of a comment and a resource that was added to the chat. Love that being culturally competent is more than just interpreting language. The meaning of the words we use, the biases and the perspectives we carry are important. Another resource to support our being more sensitive, and it's the pioneernetwork.net. That's in the chat if people want to check that out. Couple more patients with limited English proficiency stuff in the chat. Let's see, here's another question. Somebody who missed a little bit of your presentation, but said, I did see a slide at the beginning where she said she would discuss national and organizational strategies to address cultural and linguistic barriers. Could she repeat those strategies? I don't know if you have time for that. We could, do you have time to do like a quickie recap, or do you think that's too much?
Well, so I think that some of these things around, trying to get more of these education. So the certification and training in palliative care interpreting is, I would say, a national strategy. Since they, these services are more and more pooled. And I think it's interesting to think about. I will just say, though I have done some work in policy, I don't know this space well enough to think about. I will say that there are instances like at San Francisco General, our access to interpreter services was in part inspired by the fact that we were sued years ago because we didn't have adequate access. So like having laws in place around that demand equal access certainly make a difference. But I will just say that there are limitations to my expertise in that area to think about what are the work that's being done in that space specifically.
Great, thank you.
I did want to just also say, and you mentioned it briefly, Lisa, but there's a great resource to the Agency for Research, AHRQ, on actually limited English proficiency, and it's a training to help both the doctors and the interpreters be able to really trust one another and be able to ask questions back and forth. And I really thought it was a significant part of it of empowering the interpreters to feel comfortable interrupting the doctor to say, I'm not quite sure that they understood that. May I, for safety reasons, ensure that. So it's a great resource. I threw it in there, but they've got training videos and a whole curriculum. So it's a really nice resource.
Great. Love all the information shared today. Terrific.
Yeah, so anybody who has any more questions about this for us, or we could funnel questions to Dr. Kinderman because our time is coming to a close here, but I wanted to thank you so much. And this was so useful and helpful and great resources. And anybody who's seeking CEUs needs to put their name and credentials in the chat again. We're going to email you the slides, and we're going to email you an evaluation. A link went in the chat a couple times to the eval if you want to do it now. Is there anything else? Any last minute anything?
Just so thrilled that we had both of these wonderful speakers today.
I know, we are so pleased.
Thank you.
Yeah.
Thank you.
And
Great to be with you.
And thanks to everybody for joining us today. And our next session is coming up. I think it's not next week, but it's the week after.
It's May 19th.
May 19th.
Yes, with
Oh, it
Cindy.
is next week.
Yeah,
with Cindy.
Rock, and we're very excited about it.
Yeah. All right. Thank you, everybody.
Thank you.
We'll be in touch, Dr. Kinderman.
Okay, sounds great. Thank you.
Thanks so much.
Bye.